welcome you all. We're going to be talking about individualized medicine today. As many of you know, genomics and digital technology is sort of the focus of research at Scripps Research Translational Institute, where we're helping to transform individualized medicine through this research. To start us off, I'm honored to invite some key players in the field. We have Jay Wohlgemuth and Phil Febbo speaking first. Phil Febbo is the Chief Medical Officer at Illumina. He's also previously Chief Medical Officer at Genomic Health. At both companies, he's been leading efforts in driving genomic practice into clinical care. Previously, he was Professor of Medicine and Urology at the University of California, San Francisco, where he focused on genomics and clinical behavior of prostate cancer and other genitourinary oncological topics. And he got his medical degree from UCSF, fellowship from Dana-Farber Institute, and 6 years at Duke's Medical Center of Genomic Science and Policy. Jay Wohlgemuth is a Senior Vice President of R&D and Medical Affairs and Chief Medical Officer at Quest Diagnostics. His responsibilities encompass R&D, medical affairs, medical lab quality, population health, and employee health as well, where Quest is a big leader in innovation and employee health. He's also in the past held many senior leadership positions at several innovative companies, startup companies, as well as larger companies. Won several awards for technology innovation and earned his medical degree from Stanford Medical School.
Really glad to be here today. And I was talking with Ali in preparing for this the other day, saying it'll be good to talk about something that is not COVID related. And as it turns out, though, as I put my talk together today, I realized that we did learn so much from COVID-19, and it's changed so much about how we view healthcare and how we deliver healthcare. And so I really couldn't give a meaningful talk without addressing that. So the way I've structured this is to say I'm gonna talk a little bit around what I call population-based precision health. It's essentially population health and how we've been approaching it, and how employer-sponsored health plans have been a successful place to cultivate and sort of what's happening, what are we trying to do there. And then I'm going to go through COVID-19 from a Quest perspective, and I'm going to show all the different places where innovation was forced and required, and where change happened in a very positive way in the clinical laboratory side. And then I'm going to come back to, well, what are we left with, and what are some of the really new approaches that are happening in healthcare coming out of the pandemic. So I would start with the notion that to reground us to 2019, healthcare in the United States is not good. We are at the bottom of the list of modernized countries on healthcare spending, many healthcare outcomes. Engagement is poor. And by the way, we're paying top dollar for this healthcare system we have, which is not giving us a return in preventative care and in improving outcomes. And I know that's a lot to say, but it is important to start with that. Pre-pandemic, our healthcare system has not been highly effective in engaging people in preventative healthcare and chronic disease management. And so, a lot of what I've been trying to do, and Quest is up to in providing broader services to health plans, employers, health systems, and physicians, is in driving the triple aim. right? Trying to find ways to improve care, improve quality and access, and improve the cost. And we believe, and I'm going to show you from at least some of the employer work we've done, it is absolutely possible to improve on all three fronts at the same time if incentives are aligned and if a smart program is deployed. So Quest, of course, we're obviously the largest laboratory, clinical laboratory in the U.S., but a lot of people don't appreciate our connectivity to the healthcare ecosystem. Of course, we have our data, which we maintain for all testing and ICD-9 and 10 codes and related data for the last 10 years. We connect with 50% of the physicians and hospitals in the U.S. And by connect, I mean we literally connect electronically and have created interfaces to 675 makes and models of EMRs because we had to. But we also connect with half of the U.S. population every 2 years and interact with every health plan and many employers. And so we're really in the center of the healthcare ecosystem, and we feel, and we've been working very hard to then say, well, can't we then be a big enabler of population health solutions? We have the data and analytics and connectivity. We have really an amazing platform of different ways to connect to consumers directly through patient service centers, through Walmart joint venture sites, through our 10,000 mobile healthcare workers who can go into the home or go to the work site through home-based kits, right? And then in addition, the types of services that can be brought to a consumer in this model are far beyond laboratory testing and include medical diagnostics, various types of pharmacy services, mental health services, and, the sky is the limit, so to speak. We do a lot with our data to enable population health. We have an ongoing set of publications and research projects involving that data, but of course we also use it to drive population health implementation programs for our customers and for ourselves, actually, through our employer health plan. And so I want to spend just a moment on the employer side because I talk a lot about it. A lot of the data that our team has generated has occurred in the context of employer-sponsored healthcare plans. And if you think about it, a very large number of Americans are covered through employer-sponsored healthcare plans. And by the way, it's one of the pure places in healthcare where you can really practice population health because in the Quest Health Plan, for example, we have 60,000 members and we're self-insured. And those employees of ours are with us for an average of 10 years. And we have all of their healthcare costs, which is $400 million roughly. And so, those costs increase by 5 to 6% a year, every year. And the cost is often shifted in employer plans to the consumer. And so even late last year, the cost of employer healthcare for a family in this country is like buying a new car every year. So this is really, ground zero as far as a lot of the population health work that I'm going to show you. One example of the type of thing you can do here, this is one of our programs from the Quest employee base, essentially offering outreach to individuals who were found to have creatinine elevations and evidence of early renal disease. Very simple intervention of having a telemedicine consultation with a physician, having retesting and workup as needed, and referral to a nephrologist. That simple. And through that type of intervention, we were able to demonstrate, the obvious, which is as we begin to prevent stage 4 renal failure, those extreme costs are avoided. And of course, it's a great outcome, for our employees. I was providing an example of a renal intervention, population health. These same interventions and approaches, of course, can apply to many other disease areas. And one of the benefits of working within a employee health plan is we have access to our data, and we understand not only who needs an intervention, but the costs that are avoided and the outcomes. And we're able to show for every 1,000 people that we, drive this sort of program on, we're able to have real clinical and health economic benefits. So through all this work in the last 5 years, we've been able to lower the per member cost of healthcare at Quest for the first time in a decade in 2017. We have been able to hold costs flat for our employees as compared to other employers. We have saved $50 million for Quest Diagnostics health plan, and that money can then be reinvested in population health solutions or lowering the cost of healthcare for employees. For all this work, our team was awarded the C. Everett Koop Award for the best population health implementation in the US in 2020. So we're very proud of that. And of course, our employees are very happy with the hard work that we've been doing on their behalf. So all of that is to say that population health can be implemented effectively. And then in the midst of all this, as we're trying to move that direction, we had COVID-19. And as I mentioned, for Quest and for many of us, we were embroiled in this all year, 2020, and still are, doing all kinds of work to deliver on our side testing solutions mostly for COVID-19. Actually, it was just a year ago, March 9th, 2020, when we released our first molecular test. And I remember being excited about getting to 10,000 tests a day. But then over the spring and summer, we built up, the testing. We've done over 35 million molecular tests for COVID-19. But there was a bunch of innovation that happened during the year, and I'm going to pull out some of the most important aspects of this that I think really are meaningful in a much broader context than COVID-19. And the first is around, this issue in the early part of the pandemic of we had a, healthcare crisis, the likes of which we haven't seen. And individuals needed to go get tested with a nasal swab, but there was nowhere to go because you couldn't go to a physician's office or a health system to get it done initially. And so we ended up in the parking lots across the US doing swabs. Over time, we developed and launched through Quest a self-collection PCR. And this took quite an effort. We had a large study to demonstrate that a self-collected sample and various types of self-collected samples would provide equal sensitivity and specificity to a provider-collected approach. But of course, once we made that available, boy, what a contribution that was. So now all of a sudden, the person doesn't go to the swabbing event. The kit is sent to the individual's home. They self-swab, drop it in a FedEx box, no PPE. Everyone stays at home, which is of course, maybe the model we should have been thinking of all along. We even went to extremes with Walmart of having drones dropping kits on people's lawns. Sort of unbelievable, sort of Jetsons-like for me to, imagine that this is actually happening. But again, it's consumer-centric. It's bringing the healthcare to the person. We also realized that to meet the demands of, the pandemic, we would need to do new things in the laboratory. Our group was the first to have an EUA for pooling of samples for COVID-19. And, now that we've done this, we realize there are several other areas within what we do where pooling will absolutely make sense, and we should implement that. We also developed consumer-friendly models of engaging with COVID-19 testing. And this is physician ordered and overseen with telemedicine enablement, but it's directed by the consumer who engages in ordering, asking to have a test performed for them. And this type of, consumer-centric healthcare, again, is where consumers expect healthcare to go. And by the way, it's also how to engage people and consumers at scale in healthcare services. We also had to, for the first time since I've been at Quest, sort of come to an understanding of how we integrate our testing to these types of identity or QR code consumer identity applications. And we've done work with Clear. And of course, this is happening now all around us relative to proof of COVID vaccination or proof of prior COVID infection. So the other thing, of course, that we all noticed during the pandemic was that healthcare, preventative healthcare, and chronic disease management fell off a cliff. And certainly, during the spring and summer, we didn't even know how to engage in healthcare in this new environment. But people were scared to go in, and a lot of physician offices were closed. Testing for diabetes, colorectal screenings and visits to doctors are all way down. And we're able to just see this in real time based, of course, on our own testing data at Quest. And we published several articles on the same. We also learned what we already knew, which is there is a major issue with healthcare disparities in the US. And it just came to light. So, it became so obvious with COVID-19. And there are lots of different factors, including access to and engagement with healthcare among disparate populations. Also, we were able to show here with our own data sort of that, that ethnic and racial differences are very clear in access to and outcomes from SARS-CoV-2 infection. We also had partnered during the pandemic in new ways with the FDA in interacting around COVID innovation, but also with the CDC, the NCI, and others in really partnering to do research at scale, which utilizes the resources of Quest Diagnostics and meets public health, goals. And so this is a great example, is all the work that has been done. And this is a very old page here, but the work that we have done in using Quest Diagnostics sample discards, which occur all over the country every day. And these discards were not from people who were being tested for COVID-19, but from people who were coming in for liver function testing or lipid testing. We take those sample discards, de-identify them, and are able to provide them with serology testing to the CDC. And from that, there have been several publications that have come out, but the headline was that the rate of prior infection with SARS-CoV-2 in the communities at large was anywhere from 5 to 10 times higher than had been thought previously from public health data. So we're continuing to do this even today to generate this understanding of region by region, county by county, what really is the prevalence of prior SARS-CoV-2 infection, which is really important as different localities and think about reopening plans, for example. So anyhow, this has just been a really great opportunity to contribute. We then were able to also use this data to help understand over time for people who have prior SARS-CoV-2 infection, what is their risk of future positive PCR or future COVID-19, infection. And this recent paper here on the bottom right, JAMA Internal Medicine, just came out. It has LabCorp, Quest, and many other data contributors, and putting together all our data to publish and in this way. And so that's just another great thing, is working hand in hand with LabCorp. I now have their CMO on speed dial. It's just a great outcome of the pandemic. So that's the COVID-19 piece, and I think you can see why I included that in my talk. So now I want to come back to just some examples of what we're doing and what some of our collaborators are doing in this space that I think was really catalyzed by and accelerated by COVID-19. So one of them is this heavy focus on consumer-centric care. And consumer-centric care is just the notion, in my mind, of the first place that the person should be served, the patient should be served, is their home. And then the next place would be the next convenient location for them. And maybe the last place would be, I'm sorry, not everyone will like this, but the health system, where maybe you should be going in physically to the four walls when you need to have a baby or have an orthopedic surgery. And of course, there are other, reasons why, but, it's home first. And so, one of the things we've done in the employer business, employer population health offering that I've been referring to, is now when we provide testing to individual employees on behalf of their company, we will send a kit into their home. They will self-collect their sample. And then when the results come back, they will have access to telemedicine services. In one case, with 98.6, we have a program where individuals get 3 months of access to 98.6 to help them interpret and take next steps on whatever the testing was that was performed. And they have unlimited access during those 3 months, and there could be text chat and or live discussion. And then the other approach we have is really virtual primary care with our partner Catapult. And actually, I'm going to go forward to that and then come back. But in this approach, then we say, not only will the person have, the blood testing and biometrics performed, but also they provide a consent to allow us to pull all of their pharmacy and claims data. They then have a virtual primary care checkup where all of their data is reviewed and their gaps in care and preventative services recommendations are acted on. And, if you kind of think about this approach, let's go back. If you think about this approach, this person has not left their home or work site and has had, 95% or more of what is required in an annual primary care visit. So I'm really excited about this approach as well. And of course, when we work with a Catapult or we work with 98.6, we make sure that they are referring people into the appropriate providers in the person's network, right? So all of this does, in fact, connect to the traditional healthcare system and the person's PCP if they have one, or the person's specialist if they have one. So I just want to be clear on that. And so again, I think I'd mentioned this. So with 98.6, it would be literally home-based self-collection, a blood pressure cuff, and a access to 98.6 to steer people into care. A lot of what I see here is that when we do this, individuals who engage don't have a primary care physician, or they don't have an endocrinologist, and they do have diabetes. And so a lot of this is about getting a really good engagement with an individual, providing access to them, to a physician, and then getting them steered in somewhere into the healthcare system so they can engage in preventative care. One of the other areas that sort of fits into this consumer-centric home-based care theme is pharmacogenetics. Now, pharmacogenetics has been tricky and elusive for us. I've actually remember working 10 years ago with Eric Topol, if you're out there, and your team on CYP2C19 implementation studies, right? And it's been a very, very hard model because it's just very hard to deliver at the point of care that information in a way that's effective. But what we have seen in the last couple of years is this model of pharmacogenetics in populations whereby the individual has the testing performed, but then has a consultation with a pharmacist that allows them to really have not only the pharmacogenetic interpretation done, but also a full MTM or medication therapy management review. And through that approach, you're not only able to make the changes in the therapeutic regimen for those pharmacogenetic interactions, but you're also getting this added value of engaging a person who may be on 9 medications in a full MTM. And through that, in the prior example of the Kentucky State Teachers Union work, it was seen that in those cases where the pharmacist sits with the individual around the pharmacogenetic information, that in 96% of cases, the physician would made the change that was recommended by the pharmacist and patient. And we're also, as we implement this right now at Quest Diagnostics for our employees, we're being smart about it because we actually know who would benefit most. And that would be individuals who are on a medication which has a known pharmacogenetic interaction, or a person on 9 medications. And so, that's another benefit of this type of population-based design for pharmacogenetics. We are enrolling or offering it to our employees now, and together with some of our partners, Coriell Life Sciences and Thermo Fisher. And we intend to, publish the results during this year. But this is a very much a consumer-centric approach where the person doesn't leave their home and they get this very valuable MTM and the value of the pharmacogenetic information. The other thing that happened during the year was a accelerated understanding of mental health in healthcare. And I would say it sort of went from, lower on the list to really being embraced as a number one healthcare issue, particularly in among employers. And the stigma also began to melt away as there's just so much stress on society, so many people, suffering from some level of anxiety or depression. So during the year, we implemented a program with Hopkins called the Hopkins Balance Program. We offered it to Quest employees. These numbers are old now. We've engaged well over 10,000 of our employees in the program. The thing about mental health, of course, is that if someone's struggling, the last thing they want to do is pick up a phone, make an appointment, drive over somewhere, talk to someone. They just sort of want to be at home in many cases. And so this is essentially a questionnaire followed by a risk assessment. And then individuals who qualify or have a risk or issue can have a Hopkins trained mental health professional work with them for a period of 3 to 6 months and literally, steer them in to care. We've made now over 1,000 connections to mental health care in our employee base. And I actually think that's about 999 more than we might have done. It's very, very difficult for our employees and for consumers to navigate and engage with and find mental health care. The other component that is very positive that came out of this is that Quest Diagnostics in the end of 2020, based on what was experienced through COVID-19, founded a Quest for Health Equity fund with over $100 million, which is aimed at driving implementation, awareness, education, but really trying to close gaps around health inequities and find ways to deliver healthcare in an effective way to those populations that traditionally may not engage or receive high quality healthcare. So this is just a tremendous silver lining from the pandemic. We've been active, and there are lots of grants being made to do studies and implementation work around the country. Some of the early work was on COVID-19 to say, we have testing deserts within urban centers of minority populations that were not engaging at all in testing. And so here we have lots of approaches. One was to send some home-based self-collection kits directly in. Another was to distribute those kits out of churches in the community. And then on the right, we one of the more academic efforts around health inequities is our research with Dana-Farber on the risk of multiple myeloma in the African-American population, which then was extended into the impacts of COVID-19 on that same population. The work, this is just a whole different picture for, me personally and for Quest as far as, the type of research that is being done at scale now with the NCI, with the CDC, to get after these big, juicy, questions around COVID-19, trying to understand the seroprevalence, trying to understand protective immunity, sharing samples and data out of Quest, but also across the entire lab industry, realizing that our discard samples are actually highly important and can be very useful. And actually, I would say on the topic of viral variants of SARS-CoV-2, we're seeing the same thing. There's just a mobilization of many different groups to collaborate and share information in really a new way. One of the other things is we're never going to, we learned a lot about actually being ready for a pandemic. And I think, this is a really simple notion here, but Quest and other testing laboratories will absolutely be further ahead in the future. And we've learned to take very seriously the pandemic threats that are out there, particularly the respiratory viruses. And we've done a lot of work with partners to prioritize and identify the threats. And then, of course, we have to have a deep surveillance program to help us share data, understand what's coming over, what is likely to move from animal to human transmission. And then ultimately here to have a set of on-the-shelf assays ready for the top pandemic threats prior to their coming over, prior to an outbreak being established. And finally, this, catalyzed what we were already getting into, which was creating a global diagnostics network. Quest has created this network, and we have partners in every major territory around the world. I will tell you that Green Cross Labs in South Korea, shared samples with us to enable us to rapidly validate that PCR test back in March of 2020. And it is not lost on us that this type of network will be incredibly important in helping us with surveillance and readiness for pandemic threats. But then if I get back to, personalized medicine and precision care, the idea of then having a platform to roll out companion diagnostics or other biomarkers and technologies in a standard way across the world, just a tremendous opportunity. And I think we're much, much tighter now with these partners than we were coming into 2020. And so all this has resulted in an awful lot of publications out of our group. We're really upping our game as far as collaborative opportunities. There's so much to do in the space of implementation science around precision healthcare, around COVID-19 questions. And so I invite the audience, and as we go, just to continue to cultivate this space, and love to collaborate with many of you and keep this going, because I do think that we're in a different place as far as our understanding of how to deliver healthcare in a meaningful way. We learned an awful lot from the pandemic, and there were some real accelerations that occurred around key components of healthcare delivery. And so, our job security is there for us who are working on population health and trying to, make a difference here. And so I'm going to now end my talk, and we'll take questions at the end, I think, with Ali's help. And I'm going to then hand it over to Phillip.
Jay, great talk, and really appreciate all the work that Quest has been doing. Greetings. Thank you, Ali. Thank you to those organizing this Spectrum meeting. Sorry we can't be in person, but excited to participate. Phil Febbo, Chief Medical Officer of Illumina, and talking today about precision medicine, how to prevent, predict a disease, and really, with a very genocentric perspective, I would say. At Illumina, our mission is to unlock the power of the genome to improve human health. And I am biased, not because I'm at Illumina. I'm at Illumina because I'm biased. And I truly feel, as we think about our path through life, there's many things that lead to health. There's genetics, there's diet and lifestyle choices, time, and just stochasticity. But increasingly, we will see genetics and our understanding of genetics being foundational to health and healthcare. And we're already seeing this beginning. I think Jay touched upon some ways that genetic insight is being incorporated into care, and I'm going to talk more about that today. As we think about genetics right now and who we serve, obviously genetics, genomics serves a broad swath of areas in medicine and extends outside of medicine, and certainly has played a role in this pandemic that has forced us all to be virtual today. We're also seeing a lot of incredible work being done in agriculture to get to food security, to understand genetic diversity across native crops, look at the impact of genetic engineered on diversity, just incredible work going on there. Not to mention work going on in soil microbiome to understand when you see the incredible mosaic of production across an area that appears homogeneous with respect to rainfall, et cetera. Look at the microbiome in the soil and understand what facilitates growth, what retards growth. It's becoming incredibly interesting. And certainly there's many stakeholders in this. There's the academics that are early adoptions. There's the pharmaceutical companies that are increasingly using genomic insight to guide their development programs, with a growing realization that if you build a drug from genomic understanding, the path to improving outcomes for patients is shortened and more efficient. And many others are looking at genetics and genomics. And I want to talk through two examples. I'm going to talk about oncology and talk about genetic disease and touch upon COVID, and then talk about how we can really see the beginnings of these elements coming together to improve health and healthcare. So oncology is, I'm a medical oncologist and, spent my early career fighting a genetic disease for my patients, and was oftentimes frustrated with the lack of incorporation of genetic understanding in the therapies, in the management I was providing for patients, and certainly frustrated by many of the outcomes for my patients. We've been fortunate that we see a steady growth of how the understanding of the genetics of cancer are being brought into clinic and are starting to see utility as far as in companion diagnostics, where individuals with a tumor that have an event benefit from a specific therapy. And we've been seeing a growing catalog of companion diagnostics come into healthcare. And it's also interesting to look at the nature of those companion diagnostics. Early on, it was HER2 amplification, it was EGFR activating mutations. And we still see increasing these kind of focused events that activate an oncogene or knock out an oncogene. But we're now starting to see different types of companion diagnostics. We're seeing companion diagnostics that are perhaps fusions, like TRK fusions, and I'll show a slide next on that, where targeting that fusion is effective regardless of the type of cancer and the age of the patient. We're also seeing more comprehensive markers as companion diagnostics, microsatellite instability. We're seeing tumor mutation burden in this past year, where it's not about a focused single event, it's about a signature, a genetic signature across the genome of the tumor that you have to understand. And importantly, we're seeing even further of evolution to things like homologous DNA repair. So the number and nature are changing. And it's incredible to see the impact when you successfully target. So this is a waterfall plot from a LOXO study for larotrectinib. That is a drug that targets NTRK fusions. There are 3 NTRK members, and they have multiple different genes that they can fuse with to overexpress. That fusion is found at a low level across multiple types of tumors, and it's quite remarkable. What's remarkable in this waterfall plot is where you see the change in tumor volume. You see how over 70% of patients have a meaningful change in their tumor volume when they receive larotrectinib if they have a fusion. And it's those kind of responses that as an oncologist, you really just don't want to miss. And you want to make sure you find everybody who has such a fusion in order to benefit. And it's not just in the controlled studies that we're starting to see the connection of a variant with the right therapy translate into improved outcomes. This is a study of real-world data. This moves from efficacy that is demonstrated in our structured controlled trials to effectiveness, where you look into real-world data, look at patients who are being tested, patients who are receiving therapies. And it's oftentimes a different science, right? It's a science, as Jay mentioned. I mean, it's kind of this big science, data science. We're fortunate to be aggregating data, and Jay showed how Quest is really facilitating that in the setting of the pandemic and otherwise. And we're starting to understand how to look into that information and glean insights. Are the therapies we're working? This study was quite interesting, and I think this is one of my favorite comparisons, because in this, it was looking using data from comprehensive genomic profiling testing, using outcomes data from collected from electronic health records through Flatiron, a company out of New York. And this bar chart shows that of the non-small cell lung cancers who are identified as having a targetable lesion for which there was an approved therapy, the 2 bar charts show the impact of if those patients received or did not receive therapy. So in the light orange, you see those who had an event like an activating EGFR, an ALK fusion, but didn't get therapy for one reason or another. You see their survival was just over 10 months, 11 months. You see the impact when they actually get therapy that targets that goes up to 17 months. And that really demonstrates, we always have to worry about, is it prognostic? Is it predictive? Is there a true value here? But this is a really nice demonstration in real world that when you have a patient who has an activating mutation that can be targeted and they get therapy, outcomes improve. Now, this has translated into improvement at a global level. And it was really exciting to see with last year's American Cancer Society, we've seen steady improvement in cancer survival. Now, this is contributed by many elements. Prevention, right? We see smoking cessation. We see early detection with screening. But we're also seeing, comprehensive genomic profiling, matching therapies with the right drugs, with the right genetic events are also contributing significantly to this. And we are moving to a place where through a better genetic understanding of disease, we're going to be able to reduce the burden significantly for cancer and really work towards preventing, diagnosing earlier, and then when a patient needs systemic therapy, leveraging the genetics of their disease to target that therapy and ensure they get the most effective therapy. At Illumina, we're very excited about the opportunity that we're seeing in identifying patients earlier and leveraging genomic insight and genomics to detect cancer earlier. And this has incredible potential because it really has the potential to stage migrate disease from later stages, stage 3, stage 4, where all too often cancer is diagnosed, into stages 1 and 2, where it can be treated. And the impact translates very quickly into lives saved. So when you're diagnosed with late stage, it's a very high mortality at 5 years, 79%. When you're diagnosed at early stage, it's about 11%. And we're very excited and are in the process of our work to welcome GRAIL back into Illumina, and very excited about GRAIL launching their Gallery test. This test will be launched next quarter as a laboratory developed test. They've recently are partnering with Quest to enable collection from patients. And this test, the science continues to build supporting this. We'll see some data coming out over the next few months from their Pathfinder, but really shows high sensitivity, high specificity, and will move us to a time where we have a pan-cancer test, and we do have the opportunity to diagnose individuals earlier where the disease is curable and the burden on healthcare is lost. And we'll decrease, and we'll touch upon that a little bit later. Right now, though, with comprehensive genomic profiling, we are seeing that once someone does have cancer and they're under management, we've seen an evolution of where testing has gone. It started with single variants that were detected, moved on to small panels, and now, because of the nature and the number of the companion diagnostics, it's really moving into comprehensive genomic profiling. But of course, to provide best care, eventually we're going to want a full understanding of the genome. So we want the genome of the individual, and we're going to want to understand the full genome of the tumor. It's exciting that that's already happening, not only in both in research and in clinic. And, we've worked with different collaborators, in this case with Newcastle University, where they had an expert team working with acute lymphoblastic leukemia. And for patients, and this was a retrospective look, but we took patients who did not have a clear molecular event, right? So the WHO, the AJCC, everyone has moved in the heme malignancies towards a more molecular classification rather than a morphologic classification. And so in order to determine care for an individual with acute leukemia, you really have to understand what are the genetic elements of that leukemia so that you can guide your therapy. Sometimes it's not targeted therapy, it's more intensity of therapy. Do they have poor prognostic markers? Do they have good prognostic markers? How do you manage that? Because oftentimes with these children, we know that there are some long-term sequelae from that therapy, and you want to be able to manage, give them just the right amount of therapy. So optimize their chance for cure, but minimize the risk of long-term poor outcomes due to the therapy itself. In this case, of the 22% that could not either appear normal or did not have clear genetic events, we found 98% with cytogenetic results using whole genome sequencing. And we really were able to provide additional, the information required for prognosis in those patients. And it's interesting, just in the past few days, of course, that's a research that was retrospective, but just in the last few days, the Washington University investigators, and remember, I mean, many of us remember the first cancer whole genome from Tim Lay's group at Washington University. They're now talking about whole genome analysis for myeloid cancers. Here, they found, reportable significant events in 40 of the 235 patients that they performed after all subsequent typical analysis. They changed the risk category for the patients in 19 patients, so about 16.2% of the time. And really incredibly, as we talk about implementation science, they were able to, the median turnaround time for that information was 5 days. And so it's not just, whole genomes in cancer, obviously heme malignancies, sarcomas, pediatric oncologies. We'll probably see it start to enter into clinical world in those diseases. But we also know that there's a lot to be gleaned from whole genome of solid tumors. And these are just two articles of work that I've participated directly in, started when I was a professor at UCSF and had continued while I was moved into industry, and really proud of the work looking at metastatic prostate cancer, doing whole genome analysis and highlighting the additional value of that whole genome approach. And specifically in prostate cancer, we're increasingly aware of the role of BRCA1, BRCA2, and other events like CDK12, RAD51, that can disrupt DNA repair mechanisms, specifically homologous DNA repair mechanisms, and result in and have the opportunity for a significant response to PARP inhibitors. Really exciting. This is still ways away from clinical use, but it's great. It really shows the insight that's available for whole genome. And that's of the cancer. Now, whole genome on the germline side, on the person side, it's where we've really seen the benefit is in fact in genetic disease and children suspected of rare or genetic disease. And, about 5% of babies born end up in critical care, and about 20 to 30% of them are suspected to have genetic disease. Each of those, and at Illumina, we've really focused on empowering physicians and working with pioneers like Stephen Kingsmore and others to give them the tools to understand what is the key genetic event that's putting these children in harm's way, making them sick, accounting for the malformations that are seen and the disability that's seen. And one of the reasons we've really focused on this is, although each is rare, collectively it's quite common. There are over 7,000 defined genetic diseases, and we really see probably 2 to 6% in aggregate of individuals have some impact of rare disease. And the impact can be quite striking. And I think of a young boy that has participated in one of our programs called Sawyer, and he clearly was affected by a genetic disease, clearly had some developmental delay, and spent 8 years going from provider to test, and only when he was participating in the Undiagnosed Disease Network, was he able to get a whole genome and found that he had a TRP12 mutation. There are only 18 other children in the world with TRP12 mutations as of last year. What's incredibly important is, although sometimes that diagnosis alone doesn't change management for the families to finally understand what's driving it. For also many of these families reach out with each other and connect, because there's no better expert on a child with TRP12 as a family member of someone taking care of someone with TRP12. And that kind of community, those micro communities that establish, are incredibly important. And we see this happening more and more. And it doesn't have to be relegated to just, the pioneers like the Rady's, the Mercy hospitals. We've been working, sorry. All right, so, and just talking about whole genomes, as far as, providing the evidence that's required. We've seen the similar kind of walk over the past few years, from some cytogenetics to panels, focused panels, chromosome microarrays. There's growing evidence now that a whole genome provides the most comprehensive assessment, and also can provide the better information about across the full genome, and is now more readily available. Looking at a few studies just rolling up over the past few years, most often whole genome analysis and prior to the past few years has been used as a secondary test. So the bar charts on the left of this show that after chromosomal microarray, cytogenetics, et cetera, what's the yield of whole genome? So even after standard diagnostic approaches, you see whole genome can add up to 42%, in between, here 19% and 42%. When you move it into the first tier and really speed up that approach, and speed up and decrease the time of the diagnostic odyssey, you can see that steps up. So you can get from 37 to up to 68%. And these studies still reflect a whole genome prior to a lot of improvements we've done as far as deconvoluting different genetic events. Polymorphisms, pseudogenes, nucleotide repeat. The genome that we're establishing that we can now look at is getting better and better. And we're just seeing that yield go up and up. And this is what I wanted to say, because, some of these studies, they're at pioneers, they're at hogs, but we've also want to make sure that whole genome, as we see more and more utility, and as we see it recommended by different evidence review bodies, we want to make sure it's accessible. And we've started the iHope network, where multiple labs are participating in providing whole genomes to children suspected of genetic disease. And there's been a very great partnership with a clinic in Tijuana and a dysmorphology clinic there, providing whole genomes. And in that setting, of the first 60, the diagnostic yield was 68.3%, so very high diagnostic yield. And what was striking to me is that even in a resource-limited setting, when you look at how did management of those children change? So not only did we end the diagnostic odyssey in 2/3 of those children that were brought to the clinic, but the management changed in about 40% of the time in a resource-limited setting. And so we will see continued improvement, continued work for children with suspected of genetic disease and the impact of whole genome. But the whole genome is a platform, and the idea is to move towards having it as a foundational element of healthcare. And so as you think about moving from those suspected with genetic disease, you move into more all of us that have different genetics that put us at different risk for disease through our lifetimes, and give us different elements that a better understanding would lead to improved care. And so if we just focus on cardiovascular disease, and I know Ali will present talking about polygenic risk scores later, but in cardiovascular disease, there are a host of Mendelian genes that drive cholesterol, cardiac hypertrophy, arrhythmias. There are pharmacogenomics, and Jay mentioned some of them focused on things like antiplatelet activity with clopidogrel. And then there are a growing number of polygenic risk scores. So, the genome can be a platform from which you pull each of these. And the opportunities are quite incredible. If you look at just pharmacogenomics, as Jay mentioned, CPIC, which is really setting the standards as far as where is there sufficient evidence that a metabolic phenotype is associated with differential impacts of different drugs. There's very strong guidance across multiple fields. And it has been a major challenge. This is not new news, and this has been a major challenge of implementation. And if you look at why we're so far away from the triple aim, incorporating this kind of knowledge into healthcare, be it through a program like Jay mentioned, where you work with a pharmacist, or increasingly, if this information is integrated into decision support within a healthcare system, we're going to see incredible improvements. That genome can also identify carriers. So we talked about a little bit about cancer and treating cancer, but also screening for cancer risk in order to even earlier bring in interventions. And if you just walk through breast cancer, look at those who are carrier BRCA1, BRCA2, and a growing number of genes that we know alter risk. We know by instituting effective carrier screening, taking the right measurements to be proactive, to monitor more closely, screen more aggressively, and intervene earlier, we will change the curve. We will improve outcomes, and we will decrease costs. So these kind of incorporations of whole genome and information from the whole genome getting incorporated in healthcare can really have an incredible impact. And, the whole genome that we have been focused on, and it has been nice to talk about a number of other things. And I know there's a fabulous talk later this afternoon on COVID, but we've really seen, next generation sequencing working on the whole genome of COVID. It was, next generation sequencing identified as a novel coronavirus, followed it as it crossed the world and entered communities, saw how it mutated, and then, saw the emergence of the variants that have, with the first identification of B117 in the UK, B1351 South Africa, P1 in Brazil, and then, the work done at Scripps and many other places, kind of finding the variants in the United States. I do agree with Jay. I think, this has been an incredible time of coming together, and we are proud of the work that we've done directly working with the CDC, as Quest has done, where we found out, when these variants started to come up, we realized that we were well behind and we needed to start genomic surveillance in earnest. So the CDC reached out to the laboratories with reach, like Quest has, like LabCorp, like Helix and Illumina, and rapidly ramped up sequencing so that we have a better understanding of the variants in the United States. And we see that continuing in a very positive way. So, we have the technology, we have evidence of utility, and, there's no lack of access to testing. And this slide just kind of shows whether it's disease risk screening, whether it's whole genome, rare disease, pharmacogenomics, oncology, pathology. There's incredible resources around in the United States and outside the United States. And we see leaders like Quest and LabCorp also participating meaningfully. But at the same time, we do see a challenge with respect to adoption and utilization, even when the tests are available, even when there's reimbursement. This is work that just kind of walks through advanced cancer. So even with all the potential benefit, only 15% of patients with advanced cancer get a comprehensive genomic profiling and next generation based test. Only about 40% get any molecular testing. And I think when you're working with a genetic disease like cancer, that's just irresponsible. In addition, for the kids in the NICU, where we know that there's incredible benefit, only about 2% of newborns get whole genome or whole exome sequencing, even though a much larger percentage can potentially benefit. And I think a big challenge is the fact that oftentimes these testing centers are not fully integrated. And I think what I really enjoyed about Jay's talk is he's showing how Quest is integrating multiple elements, and testing is just one element of healthcare. But oftentimes these genomic tests are aside from healthcare. They're in high quality providers, and it's harder to integrate into the EHR, harder to integrate into decision support. And I think what we really have to do as far as the leaders in healthcare moving forward, we'll figure out how to integrate this and really look at the ecosystem of care with this, with the different genomic elements being one of the elements that is fundamentally incorporated, be it, quality of life with monitoring, using prognostic scores, understanding individuals' risk, and in coaching them on the right choices to live the healthiest life possible. We also have to be proactive with screening because even genetics can't give you your full risk. You have to be proactive. So we'll see incredible opportunities to be more proactive with screening for cancer and other diseases. And then when someone has disease, you want to do genetic-driven therapy and incorporating that in a way that busy physicians can really adopt and incorporate and improve outcomes quickly. I think, and then as you're doing that, we're only going to get to a place where that bears the best fruit if we get to the learning health system, and where that system is going on, care is being provided. And if you look at the left, part of this slide, that's where an individual patient is benefiting from that incorporation of that insight into their care. However, just as Jay said, those patients should be given the option to opt into the learning system where their outcomes, their results can be incorporated with others in a way that protects their privacy, protects their confidentiality, but then builds so that the next person who gets that test benefits from the last person who gets the test. And I do think that the leading medical centers of the future will figure out how to complete this loop effectively and in almost real time, bring that insight right back into care. Now, of course, additionals to the healthcare system, Jay mentioned the challenges with healthcare costs. You can't talk about improving healthcare without understanding cost. And I'm actually going to kind of flatter Jay by showing data from one of his publications. And this is just to emphasize, Jay's done a great job understanding costs as the 60,000 lives that Quest covers. And if you look at where some of the major costs are and where healthcare dollars are spent, there's incredible opportunity, be it cancer, cardiometabolic, pharmacy, to incorporate all the information that I've talked about with cancer, with pharmacogenomics, with carrier screening, to really directly address that. So by being more proactive, there are costs that can be avoided. We know that our healthcare system spends hundreds of millions of dollars each year on side effects from drugs that could be avoided if pharmacogenomics was broadly incorporated. And there are many other opportunities, such as diagnosing early. So, in conclusion, I think as we think about predictive preventive medicine, as we think about moving towards using genomics to improve outcome, there's ample evidence that when genetics are driving a disease or genetics are putting people at risk, you can leverage that information to understand how to prevent earlier diagnosis and to treat. The outcomes can be improved for the individual, but the outcomes can also be improved for the system with respect to more efficient, less costs to wasteful or ineffective therapies. And I do think we have to continue to commit. We have a lot to learn. There's incredible opportunity to leverage the big data, the advanced analytics that we're developing to really create systems where we learn and improve in real time. So I want to thank again the organizers and thank for some time talking to you today. And I guess we now open it up for some questions.
Before we start into the questions, just wanted to thank the speakers, Phil and Jay. They took away my reaction, so I'm just gonna clap on my own.
Hey.
Thanks so much for the great talks, guys. I'll start with a question sort of related to the last point in terms of costs. So Jay, you presented a nice scenario with Quest employees. They have a pretty long tenure at Quest, and it's pretty preventative health, preventative medicine is convincing in that environment. But of course, there are many people that don't get insurance through an employee turnover can be relatively rapid in other sort of companies, that sort of thing. It strikes me that the U.S. healthcare system in general, or at least the way reimbursement is done, is not well suited for long-term prevention. I think a question for both Jay and Phil. What do you think about that? What changes are sort of needed to really get long-term prevention, paid for and implemented?
Yeah, you nailed it, Ali. I think this is why I'm so excited about the employer-sponsored healthcare for exactly this reason, because it's one of the only places I can find that is those incentives are just so clear, right? And in 10 years is, a lot of companies might have individuals for 8 years on average. We have people at Quest for 40 years, so we're in the game of ensuring sustainable healthcare costs and preventing chronic disease, and the incentives are there. In other parts of, if you kind of look around, Medicare and Medicaid should be that way, but it's very, very hard to affect population health through that. And there are also political reasons why it's very difficult to take money away from current seniors, to invest in population health, frankly. And so that's difficult. There are more and more incentives that are being brought in with health plans, being brought in with ACOs, and with the Affordable Care Act. There were some, we're moving that direction, but it's slow going. And so I think that's where we should look to. That needs to evolve before what I'm looking at in the employer side could fully be implemented, in other parts of healthcare, because the incentives just aren't fully aligned.
Yeah, I think, the time frame is super important because, for some of the interventions that Jay talked about, some of the testing that I'm talking about, the challenge is that the cost is upfront, the savings is oftentimes delayed, and it can be delayed beyond the 2 to 3 year lens through which a lot of private payers use, because there's such big turnover over covered lives that when they look at the health economics from their perspective, that upfront budget, they never realize the benefit for the life that they're covering, and that person never realized the benefit. And, and I think that's why it's not surprising single payer systems like the UK, which have many other challenges, but you see the UK starting to do whole genomes for children with rare disease. That's commissioned now. It's just covered. They're doing whole genomes for hemolignancy, for sarcomas, as just covered part of policy, because they see that they have the patient their whole lives, and they see that benefits. That's why you see the NHS has inked a deal with Grail to start kicking the tires on that testing, because they see great value there. So it is a challenge. I do think, and I do get a sense though that payers are understanding that we have to, everybody knows we have to control healthcare costs. Everybody knows that there are different ways to improve and avoid, the late stage, medically intense, very expensive episodes. And I do see an increasing willingness to talk about ways to incorporate specific elements into care, into coverage. So I think we're moving in the right direction. I think there's still big challenges to how fragmented our healthcare is. I agree with Jay that the employer-based healthcare is fabulous. Medicare has some very good examples of where they've been proactive, because they do own, they do cover the patient for the rest of their lives. So I think they do have a longer term perspective, but they have other constraints. Medicaid's very hard because of the state by state policies that are set, and that becomes a very challenge.
So do you think sort of cost, and cost is the main driver there. So give you another sort of example. You spoke about Phil, you spoke about the utility of whole genome sequencing in rare disease, and where there might not be ever really a financial return on investment there, but there is definitely, like you mentioned, personal utility there in terms of getting in the right networks and learning what works and doesn't work. Maybe that leads to cost savings over time. But if only 2% of people that get that sort of benefit are getting whole genome sequencing, how do you think about that in terms of, I guess, non-financial utility?
Yeah, so I think we're exquisitely sensitive to understanding the financial implications. So, we're looking for utility as far as, we're really driving to improved patient outcomes, because our system, needs to get to more efficiency. But, I think the system is able to support efficient care moving forward. With this example of genetic disease, there's very good data that came out of the Baby Bear project in California with rabies, and they'll be, this will be publishing soon, where there is a cost savings to the system, because by getting to that diagnosis, the downstream care, which is very expensive for children in the NICU, is more directed and more effective, and so we do see, even in that setting, it really is this balance between the upfront cost that requires to help manage, understand someone's risk and help encourage them to take the steps, either dietary lifestyle risk, engage with the health system appropriately. That's labor intensive. I mean, I think, Jay, you can talk to that. I mean, some of the programs you talked about, that takes real proactive work. You need to hire people. You need to, get, and the patients will benefit and the system will benefit. And I think it's really that upfront cost, whether it's a diagnostic or a interventional team that's calling and really helping a health navigator team, covering that, and then with the benefits over time. That's a lot of the challenge we face.
I'd just add in here, I do think, though, that for whole genome sequencing for rare pediatric disease, to Phil's point, there is a very clear health economic argument there. And I've seen it in several different studies. And if it's done early in the Odyssey, you're going to save the system money. So what it comes back to, though, is that who's watching the system, right? Is if that system is an employer plan, and it's a slam dunk, right? But if I'm in another place where my incentives aren't like that, I would say, though, I think the big insurers, United Healthcare, I know, has a really progressive policy around this very matter, where they'll say, if you meet criteria, we will send you to a leading pediatric center. And if they want to do whole exome or whole genome, they will do it. It's covered up front. It's a, so I think some of the payers see what I'm saying, which is, in the right, if you use it in the right way on this pediatric genetic odyssey, it absolutely pays off, All
right, great. All right, slightly related question in terms of testing and access to testing. Jay, I really like the things you were talking about in terms of, consumerization of testing and moving towards this kind of direct consumer model. I wonder, or the sort of the home first based testing as well. But there's a physician involved, in many steps, or at least a couple steps in that process. And I think that's great. If, the physician should certainly be notified of results and that sort of thing. But I wonder, do you think that, we'll get to a point where, are there tests that could just be routinely ordered at home, without requiring physician intervention, that sort of thing? I'm thinking like, a basic cholesterol test. Are we at the point now where we can trust people to order a cholesterol test, get it at home, understand the result, and then have the option, to talk to a physician afterwards. And, maybe for Phil, are there any genetic tests that might eventually fall into that realm of basic and routine?
Yeah, I'd say there's a certain reality around this, that you can go online right now and order a lab test for yourself of almost any kind, and in almost every state. And so there's this kind of access out there. However, when I talk about consumer healthcare, I'm talking about consumer-centric. And we have an approach that says we will always have physician ordering and oversight, and we will always have physician interpretation for positives and access to a telemedicine consultation, right? And that's kind of like a hard line on the way you can go on right now to Quest Direct and order a COVID test, but there will be a physician ordering it and overseeing it and reporting to the public health authority. So, I think that absolutely we're going to get to a place here soon where you can, as a consumer, order testing wherever you want online, and you're going to get access to it. I hope that, Quest will always have it, and that others really should have. There always needs to be some access, in my view, when that test is made, and they don't have to have an appointment with a doctor, but access is actually critical, even for minor things. I think just having a doctor to call.
Yeah, I do agree that there's going to always have to be that guidance. We've seen an incredible shift from hospital-based care to clinic-based care to home-based care, and COVID certainly accelerated many elements of that. It was already moving in that direction, but it's moved even faster. I think as we see more people get vaccinated and we get, through this pandemic, we're going to have to reassess as what the right balance, but it's an incredible opportunity. We've seen, consumer genetics come into popularity with ancestry and genealogy. Increasingly, they've provided some elements of health in those reports. How we transition and when it's, there's enough awareness and so that information can be provided safely to individuals without causing them to go back online and order a bunch of unnecessary tests. I think that's the real challenge, is raising awareness and letting that happen as there's enough awareness, so that we're not going to harm people by providing access to information that can easily be misinterpreted. So I do think it'll be home-based, but I do think having physicians, healthcare providers, genetic counselors participating is incredibly important.
Great. Unfortunately, we're running out of time. I have a lot of other questions for you guys, actually. I'll take one from the audience, if you guys can comment, sort of rapidly. Then we got to move on to the next session. We have a question from the audience. Could you comment on your educational efforts to educate patients about genomic testing, health outcomes, benefits, that sort of thing?
Phil, you want to start?
Yeah, I can say we're dedicated. We're building a whole medical affairs team, and their primary mandate is education. We're working with most of the societies, working on physician level education. And we're also, starting to collaborate more and more with larger groups, with some of the direct to consumer entities to move toward patients. So right now we feel like there's a lot of physician education that has to go, and we have a relatively small team, so that's our focus. But through partnerships, we're working too on patient education as well.
Right. Same here. I think physician education is always there and is always important. But now that we're engaging all these consumers, every time we engage, we educate. And then also I would just call out the other healthcare professionals, like the pharmacists, like the genetic counselors, that are increasingly, that's where some of the action is on this. So we do a lot of work in those, with those ancillary groups.
All right. Thanks again, Jane, Phil, for the great talks. You guys are really moving forward the space of individualized medicine and preventative care. I think it's really exciting, and COVID seems to have accelerated some of that as well, which is nice. at least a bright spot.
There were many
Otherwise-
silver linings, no question about it. And thank you for having us this morning.
Yeah,
Appreciate
thank
it.
you, Ali, and thanks everyone.
My pleasure.